2 years.
All right, everyone, we're going to go ahead and get started if y'all want to take your seats.
Thank you.
My name's Logan Pike. I'm one of our state government relations managers here at Heartland and work on a lot of our healthcare and welfare issues. I'm not going to go over their full bios because they're all very distinguished and we would take up half the panel just doing that, but I am going to introduce them. Their bios are in your program. To my right is Michael Tanner with the Cato Institute. And then Judson Hill's next to him from the great state of Georgia, and Aaron Dallek with Opternative, and he'll talk a little bit about what his company does. Company or organization? Company?
Company.
Company, okay.
Yeah.
So I know the majority of us are hoping that the Affordable Care Act either somehow gets repealed or rolled back, but we kind of created this panel with the idea of talking about free market healthcare reform and what we can do to still give people the opportunity to still have healthcare in their control, in their hands, make their own decisions. So just jumping in, talking about the elephant in the room, the Affordable Care Act. How are states reacting to the failure of the exchanges or the insurer withdrawals? And Michael, you might be the best person to answer that question.
Sure. Well, I would suggest right now that the states are taking a couple of different approaches. One is on terms of the exchanges. There's an increasing move away from state exchanges to the federal exchanges. A lot of states that tried to set up their own exchanges found that they were not very successful. Hawaii, Oregon in particular were disasters. Maryland is still trying to figure out how to get theirs together. So there's a lot of problems putting together state exchanges, and a lot of states have simply dumped the problem back to the feds, which is where it should have been to begin with, in all honesty. In terms of insurers leaving the market, that's going to be a huge problem, and that is one that the states have not yet dealt with. That is going to be a problem. About half the counties in the United States are going to have only one insurer offering plans through the exchanges by the end of next year, if United follows through on its plan to pull out, which I think it will, which is going to be an enormous problem. One thing that in particular that the states should watch is whether or not they're maintaining an individual market outside of the exchanges. I mean, basically, if states have let the exchanges sort of subsume their individual market and the individual market is sort of withered away outside of the exchanges, that's going to be a problem, because if then as the insurers pull out, there's no alternatives on the market in terms of individual markets. So that's something they're going to have to watch about. The other problem they're going to have to watch in particular is going to be whether or not this does lead into an adverse selection problem. Basically, the ACA was set up with the idea that you were going to have about an 80% medical loss ratio. That is, insurers were going to pay out about 80% in benefits of what they're taking in premiums. In about 20 some odd states, the insurers are paying out between 80 and 120%. In about 10 states, they're paying out over 100% of what they're taking in premiums. And that obviously can't go on. They're having to jack up premiums to measure that. And state insurance commissions are pushing back on the premium prices. And that's why insurers are pulling out of the market. That's going to drive up premiums still more. People are going to drop out of the market because they can't pay those premiums. And that's going to mean that more and more insurers are losing money. You could lose insurers altogether if that continues.
I think that's a good point. I was going to ask this later, but I'll ask it now. So the ACA creates, say, artificial competition. How and why does real competition in the market create a stronger healthcare system?
Well, I mean, the ACA sets up as what's called managed competition, which is essentially that you can't compete on the basis of price, or limited competition on the basis of price, and you can't compete on the basis of managing risk within the market, which is basically what insurers do, is manage risk. So essentially you've turned them from insurers into sort of prepayment mechanisms for healthcare. And they're responding, as you would expect, by trying to lower their costs, essentially by raising premiums, raising deductibles, essentially cutting back what they can pay in that regard. That's driving people out of the market for buying insurance, and that's, of course, requiring them to keep jacking it up, you end up with a sicker and sicker insurance pool of adverse selection, which is a real concern of what's going on there. The question is going to be, is there going to be some way to try and artificially force insurers back into the market or force them to insure people that doesn't otherwise want to be insured? And I'm not sure what there's a mechanism to do that's going to work.
I don't know if that was intended either. I think the intent is probably single payer. You force the market to collapse, and then you end up having to search for a government solution.
They wanted it to fail.
Do I need to move this up a little?
I want to bring in Aaron to give you a chance to talk about Opternative and just let our audience know what it is and what you created with that.
Yeah, absolutely. So I'm the CEO and co-founder of Opternative, and we've created the most convenient and affordable way of getting a prescription for glasses and contacts using just your computer and your smartphone. For patients who are 18 to 50 currently, and we're going to be expanding to more age ranges, you're able to go on your computer, sign up, use your smartphone as a remote control. The computer is like a digital eye chart. You're covering one eye, answering questions similar to how you would in the doctor's office, and you go through that process. For $40, you can get a prescription for glasses or contacts, and it's sent to an ophthalmologist who reviews it and then issues you a prescription. And this is store and forward telehealth. We're practicing in 37 or 38 states right now. We keep expanding to more states. Unfortunately, we're not in Georgia. Georgia passed a bill to ban us in Georgia, which is unfortunate. We're here to persuade you guys not to do that, to show that technologies like ours and allowing for the market to open up to innovation, to allow for companies like ours to innovate and provide accessible, affordable, safe solutions that are alternatives to the Affordable Care Act.
And that was going to be my next question these are all mainly state lawmakers in the room. What are the reasoning behind the other 23 states, or sorry, 13 states that have not embraced
And I was going to ask
telehealth
about
or not
my
embraced
contact prescription, so I guess I'm out of luck right now.
Yeah, unfortunately for you, you're not. While you're here, you can do it.
If we have all free market friendly lawmakers in the audience, what are
so there's only 3 states that have passed laws to block Opternative: Indiana, South Carolina, and Georgia. States that should be pretty free market if you're looking at that. And the reasoning behind that is because of the entrenched interests, strong lobbying efforts. That's what it comes down to. And we get that. That's the only real reason that any legislature would kind of go after what clearly is an innovative solution similar to Uber and Airbnb that's opening up access to patients who can't leave their home, who work 2 jobs, 3 jobs, have children. We have so many people who give us such great feedback, that talk about how someone said they work 3 jobs, they have 2 children, they did it at night while their kids were sleeping, right? This is the kind of things that we can do. We did a study, nearly 10% of people that have gotten a prescription say they don't have access to an eye doctor, right? And so that's in the US. This is not India, this is not, right? That's in the US, that's that's your constituents. And so I think that's the argument for technologies like telehealth. It's not just Opternative, right? This is all telehealth providers that I'm arguing for, and making sure that there's strong, free market, open regulations that still have some regulation, right? We don't want just anyone writing a prescription for controlled substances, right? You don't want this to be a pill farm. That's not what this is about. But this is about making sure that in your states, companies like ours can innovate, provide safe and affordable and accessible care to your constituents.
Are there any reasons or reasons that you've seen in states where they have been fearful to embrace this, and what are the arguments against that?
The legislatures?
Sure.
Yes, I mean, Indiana, South Carolina, and Georgia the optometric associations have had a strong presence in those states, and so Indiana is a perfect example. They had a pro-telehealth bill in Indiana that everyone in the medical industry really wanted, because telehealth in Indiana was really hard to do because of a lot of the current regulations. And the optometrists came out swinging and basically said, we're killing this bill. We are going to kill this bill. We don't care. We don't want to talk to anyone. We're just killing it. We're killing it. And they started calling I don't know if there's any Indiana legislatures, but you probably got a call from a lot of optometrists, and they're very well organized and very strong. And they basically said, we're killing this unless you block the prescribing of glasses and contacts. And they didn't care that by blocking this bill, it was going to block, telestroke, it was going to block all these other great, very beneficial technologies that are great alternatives to, to what is now a system that's, having troubles, right? That's the issue. Is they were like, we want what we want, and we're going to block this bill no matter what. And so we weren't there. We didn't know what was going on. And unfortunately, everyone kind of said, we want this bill to pass. And so they did that. We're now going back in Indiana with the hope of adjusting it. We think we'll succeed there, and potentially in South Carolina, hopefully in Georgia. But that's the kind of thing that is the hesitation. It's not on the merits. It's just on the lobbying effort.
Sure. Judson, I want to bring you in and talk a little bit about direct primary care. I know that you introduced a bill in Georgia. For anyone that doesn't know what direct primary care is, can you just explain what it is and your experience with that in Georgia?
Sure. Thank you. Direct primary care just gives the patient the right and ability to have a direct relationship with their doctor. Novel idea. Without the insurance company interfering. So we wrote legislation that's passed in a number of states, which allows you to enter into a monthly contract with your physician, usually on a primary care for all sorts of wellness type issues and all, but from primary care type procedures and analysis. And so you can pay your doctor $100 a month, $300 a month. We actually put a limit. A lot of states have limits, like a dollar limit. We had a $6,000 a year limit, which is $500 a month, of course. And to say you can do that, well, most states, that's considered an insurance contract. To say I'm going to pay my doctor $300 a month on a contractual basis. There's certain abilities to terminate the contract on both sides. And if it's out of their scope of practice, then they're going to refer out, just like any other physician would refer out. The insurance lobby in our state is extremely powerful, and they wouldn't even allow the bill to have hearings most of the time. That's how powerful they are. And the insurance committee is they did everything they could to avoid a vote on a bill in a committee.
Wow.
So, and you can see where all that's going. And they got into all the discussions about concierge, which is a different concept, but concierge, and you're going to destroy the insurance market. But this really is this, and for the conservatives in the room, I was advocating that this is a great alternative to expanding Medicaid, because we're targeting the individuals that are in the potential expansion market, that are working individuals that cannot afford primary care. So you could be $100 a month, $150, $200 a month individual, or you could do that for your family, etc., and you could have access to primary care doctors, which all translates into incentivizing wellness, having a healthcare system instead of a sick care system, and working on the healthy and keeping you healthy, because the healthier you are, the less likely you'll show up in the emergency room for free. So you can see where the argument's going. Yeah. It seems to be logical, but the insurance lobby just frankly crushed it, and that's what I hear from the doctors for patient care.
Yeah, we have direct primary care in Florida, where I live, and there was a story or situation where there was a truck driver where he was diabetic, and he lost his job and he wasn't able to go get another job without showing that he was able to drive his truck. And since he didn't have health insurance because he lost his job, he went to a direct primary care facility and was able to pay $100 to basically be cleared so that he could get a job and provide for his family. So
it's a great opportunity. The interesting part was some of the other opponents were the guys that didn't want to have any financial cap at all on it, which you got to leg in sometimes. I mean, fundamentally, I think you should have the right to talk to a doctor and pay your doctor, right? But we'll be back for round 2 next year.
Michael, is that an issue at Cato that you all have looked at?
We've not done a great deal of looking at this, but we would be very supportive. There's actually an interesting history, if you actually want to go back to this, to lodge practice medicine. The first part of the 20th century in the African American lodges, one of the ways they got into the insurance market, if in effect, was that each member of the lodge would pay $1 or $2 a month, and they would then contract with a physician to be the doctor for that lodge. The Prince Hall Masons and other groups like that used to do the Odd Fellows and some other groups like that. And at one point, about 1925 or 1930, there was more African Americans with insurance than whites in this country, largely because of this network through the lodges. But it basically was wiped out in the 50s as the regular insurance market, combined with the Flexner Report and some other things, basically wiped them out.
The insurance companies want to be in that arena, obviously, and so they want to block your ability because they want to actually dictate who can get care and what are the terms.
I know at Cato you've looked a lot at consolidation of physicians, and in my state, in Florida, we've seen a huge doctor shortfall, and part of it is just due to the increase in elderly population, but I think part of it's also due because of the scope of practice, and there's been this idea of consolidating doctors, and is that attributed to why we've seen such a shortfall or physician shortage?
Well, it's part of it. It's a contributing factor, and this is something more so with hospitals even than physicians that lawmakers should be aware of. In the years following the ACA, there's been a doubling in the number of hospital mergers in this country. I mean, essentially, small independent hospitals are not able to effectively compete in the market that the ACA has created. It is essentially designed around large conglomerates, and so the big hospitals are buying up the small hospitals, which is really hurting rural areas and also urban inner city hospitals. Those are the two that tend to go away, and you tend to have bought up by the giant conglomerates. So that's something to worry about. In terms of physicians, the independent physician, Marcus Welby's gone essentially, and they are increasingly moving now into practices that are either owned by the hospitals themselves, sort of hospital-based practices, or else into concierge type of practices where they group together. But doctors are basically, again, not in the ACA environment, are not really able to simply set up a practice on their own and really survive in this market. So I think we are seeing not just a shrinking in the number, and we're about 150,000 physicians short nationwide of what we need to be in terms of maintaining our physician ratio. But it's not just the shrinkage of the market, but it's also the market is moving into a more corporate type of medicine and less patient-centered type of medicine, and that's something to watch.
Would expanding the scope of practice I know we've seen physicians that have gone part-time, and we've seen physicians kind of take a step back in influx of patients. Would expanding the scope of practice to nurse practitioners or physician assistants help with this doctor shortage?
Be an enormous plus. Essentially what's happened is doctors are kind of moving up market, if you will, because the amount of knowledge, medical knowledge out there is huge, and doctors are becoming more and more knowledgeable, but also more and more specialized as they move up market. And it leaves a gap where the sort of general practitioner used to be. Now, what would happen in a normal market is that gap would be filled by the next rung down. The nurse practitioners would become more knowledgeable, move up into the gap that's being followed as primary care physicians leave. That's not happening because of scope of practice laws, which is essentially keeping a ceiling on them and blocking them down. And you're creating this donut hole in the middle where you have a lot of specialists, a lot of doctors up here who are really knowledgeable in this sort of stuff, a lot of nurse practitioners doing the work down here, and nothing in the middle. You really need to get rid of that ceiling and allow everybody to sort of move up a step, rung in the ladder, if you will.
Can I speak to that? I'm more cautious about expanding scope of practice. I mean, there's a couple of arguments. One is we want to serve the rural communities, and we're not having physicians, we're not having hygienists, we're not having nurse practice, we're not having people serve people, and we're not having the medical professionals serve people in rural parts of our states. However, every time that I've seen, and I chaired a national study committee on scope of practice, every time you see, if you look at the statistics, those that get the expanded scope of practice don't go to the rural communities where we need them. They end up in the metropolitan areas because it's all fair and it's all free market, and we support that, but it's free market, and they want to be where the highest dollar is. And they want to be where everybody wants to live. And so we're not solving the rural health, we're not addressing the rural healthcare issue. The other is
where we could bring in telemedicine.
Yeah, that's true. I also have a high concern about skills and levels of care. And you go, well, everyone's trained the same. And my daughter's starting Baylor University next week, and she wants to be a physician or a PA, and I applaud both of those. And they're great. And this is not about PAs and nurse practitioners and hygienists versus dentists and the rest of it. But I want the person that's tasked with seeing me to be very well trained with the best technology and the best professional skills that are out there for that practice group. And I don't see all the mid-levels, though we need thousands of them, I don't see them trained at the highest level. And I'll end with this personal example. I've got a brother-in-law and a really good friend, both have had throat cancer in the last 18 months. Brother-in-law was stage 4 throat cancer. Good friend was stage 3. Thankfully, Emory University has created some world-class technology that's innovative and saved their lives. However, their dentist found it, not the hygienist when they were having their teeth cleaning. It was the dentist who came in afterward that you've probably all experienced. So the hygienist is sitting there cleaning your teeth, and then the dentist comes in and started looking, and that's who found it. And so that's a concern for me, is if the hygienist can come in and clean the teeth, which applaud it, they don't have the same level of training and frequency of seeing this. So we got to be a little bit cautious as we expand scope of practice, unless I hate the word, unless we mandate training at a higher level to accommodate for the medical skills that I think are required.
Well, let me just tie this into the telemedicine issue.
Yeah,
because
I was going to
say, because there is an issue here in that. A famous case was in Minnesota and South Dakota a few years back. South Dakota they were trying to set up essentially some clinics that were going to be telemedicine clinics tied into the Mayo Clinic in Minneapolis. And the South Dakota Medical Association blocked it because the Mayo Clinic doctors didn't have admission practices in South Dakota, and said, well, they may be Mayo Clinic physicians, but they're not South Dakota licensed physicians, so we can't do telemedicine clinics tying into them. I mean, essentially the existing interests, I think, yes, there are certainly safety concerns and health concerns, but the existing interests primarily benefit the existing interests.
So you're right. Go ahead.
I just wanted to add. So, a perfect example is talking about serving the rural communities, which many of you guys have in your districts. Cleveland Clinic is one that I'm very well aware. They have many distance centers. They have lots of telehealth providers. What they do is they have these distance clinics where they have the doctors sitting in their Cleveland clinics, and then they're providing the doctors, but there may not be an ICU doctor at all in the facility whatsoever in a rural area in Georgia. But there'll be a nurse there. And so it's not so much that nurse needs to have expanded privileges. And I'm not going to say one way or the other. Like that's for your states to have that argument. I think that there's way too much influence on the current interests in all legislatures across this country, and that's one thing that I've been in lots of state houses. Pete, my director of government affairs, has been in lots of state houses, and if there's anything that's a problem that I see is that you as legislators have to deal with making decisions, not just what's best for your constituents, but how do you deal with all of these competing interests that are ultimately going to potentially have an impact on your ability to get elected the next year. And that's one of the challenges, because you're looking out for your constituents, but you're also looking out and saying, well, there's the insurance companies, there's, in my case, the optometrists, there's the ophthalmologist, there's the nurse practitioners, and those are all coming into these decisions, which you have to get them as experts, but ultimately you and your colleagues are the ones that have to make the decision that's best for your constituents. And I just wish that it was a group of people that was really doing what was best for the constituents and not what was best for the current special interests. And that goes to certificate of need, which I know we're going to talk about, right? I mean, it goes to a lot of these issues. And so from the telehealth standpoint, I think that technology is a big solution here. I think there's a lot of opportunities with that tele ICU where you don't even have an ICU doctor there, but you have nurses that can, shock them. You have nurses that can inject the medicine, but you have the doctor at Cleveland Clinic that is specialized in this telling them, and they zoom in. They have these machines, they have these cameras that zoom into the IV bag, the littlest thing, and so they can see everything that's going on. So I think that there are solutions. I think technology is a good one. I'm not saying it solves the 150,000 doctor deficit, but there are ways of doing that our current system's not necessarily solving.
Great points, and I'm going to balance with what I was saying a second ago. If you also required in the expansion of mid-levels the telemedicine piece, then that solves many of my concerns, addresses many of my concerns. Otherwise, we're going from 0 to 60 with, you pick a mid-level, I'm not going to pick on one, but you go to 0 to 60 and say, without any restrictions, any guidelines, literally. So to Michael's point is, you're in Minnesota and you can't see somebody because you're not licensed in North Dakota. The licenses are probably very, very similar. The test is probably identical, et cetera. Those are challenges. Those are things we can overcome. But I think a lot more people would have concern, and I'm not making this up, if the person who was, quote, reviewing the reports, quote, reviewing the reports is sitting here in Australia or New Zealand or India. And so you got to create a framework that is within the telemedicine context and using that, because that's a whole different equation. If you're using telemedicine in rural America and you've got a nurse practitioner there, but you've got somebody who's also bringing in some scope, then let's go do it like this afternoon.
Yeah, I think it's a good solution. And I know there's like 17 state compact for licensing. I think it was roughly. I think we need to expand that. I mean, I can tell you from experience that we're spending so much money getting doctors licensed across the country, and it's, they say it's going to take 3 to 6 months. It's sometimes taking 9 to 12 months in some states to get doctors that have licenses in Illinois or California or New York, or to get them licensed in lots of different states. And it's a lot of work and it's a lot of cost.
There's also a famous study by Milton Friedman who looked at medical licensing and found that the medical licensing requirements were directly proportional to the number of AMA members in a state. The more AMA members, the stronger the licensing requirements would be, and there was no difference in outcomes as well.
Aaron, this is the last, subtopic area before we go to the audience for question. You brought up certificate of need. Yep. It's like I don't even need to be up here. But what are certificate of need laws? How are they hindering competition, driving up cost? And that's directed to anyone. I know. I think Georgia was dealing with this issue last session, possibly. I know Tennessee got rid of certificate of need laws, and there have been states that are looking at partial repeals, and that's kind of another question. Is that enough, or is that a small step? Anyone that wants to address that issue?
You want to talk about Georgia?
Georgia, you mentioned Georgia, but it just had one individual, one legislator introduce a bill, but it didn't. We
Didn't go anywhere.
We actually expanded some of that. We have two legislators here from Georgia, probably 5, 6 years ago, with Cancer Treatment Centers of America when they wanted to come in. But at the end of the day, is my personal experience is when your governor drives the certificate of need changes, things can happen. If the governor's not personally engaged, then the hospital lobby will dominate, and they'll hire not 5 or 10 lobbyists, they'll hire hundreds of lobbyists. The challenge, we got a screwed up healthcare system, in my view. I mean, you got economic incentives that you couldn't make up except if you created a system like this. And we got all the different entities that have learned to profit within the system, whether they're the medical professionals, the insurance companies, the ambulatory surgery center concepts, the hospitals, et cetera. Everybody's learned how to play the game, and now we've got these perverse economic incentives from the Affordable Care Act or Unaffordable Care Act that are really impacting, as Michael was saying, what's going on in healthcare from the consolidation of physician practices as well as hospitals. And so then we enter in and have certificate of need, and we put requirements on some and no requirements on others. Many hospitals are, quote, nonprofit. Any of us in the room can be nonprofit this year. I'll show you how. Spend more money than you bring in, and you or buy more stuff than you have, but you still have the asset. But I also advance, and I'll by way of another example is, if a guy who's building the 4th gas station at the major intersection and wants to do it, he should be able to do it. It's up to them whether they think that they can sell more gas and more retail products at the gas station. Why should the free market tell them no? But the hospital context has all these perverse economic incentives, and I think we got to look at a bigger picture to solve it.
Actually, I think the ACA has done away with whatever Slender, Reed, CON stood on for a while. I mean, there was some idea that basically supply generated its own demand under the old full insurance model. That essentially, as long as there was a third party paying for everything, you bring in a new MRI unit and you go out and advertise it. Notoriously in Maryland, where I live, there was a radio station that used to say, "You having trouble with your golf swing? We come in and get an MRI, and it's fully covered by insurance." And so it was sort of, we have to recoup our capital investment, and that's how we do it. Well, but one of the things about the ACA, which a lot of people don't like, but it's driven up deductibles, and so that people are paying more out of their own pockets. So those sorts of things aren't as attractive anymore, and you're not getting that kind of incentive that's in there. Healthcare costs overall, we know, are higher in CON states than non-CON states because you've reduced competition. And there was a terrific study out, I believe it was last year, out of George Mason, that showed that in particular, it's poor and minority communities that are most hurt by CON. That basically that's where the new construction doesn't take place, or the new MRI unit doesn't go in, or they cut down on the number of hospital beds and so on. In those areas, it's not actually the suburbs. It's the people who play in the suburbs know how to play the game and to lobby the governor and to get that CON approved. It's basically urban inner city areas that get left out.
And I admit that I'm not an expert on certificate of need, but my lawyer, who I pay a lot of money to, has worked a lot in this area, and we've shared a lot of conversations. And one of the salient points that he made was that with certificate of need, the competition was the primary, but the secondary was that there would be more hospitals and beds going into these rural areas, right? And that's what would happen when you couldn't put a hospital in downtown Chicago because Northwestern had a hospital there, right? You were going to go into Decatur or into another area, and the issue is that that's where the demand is. That's where the good patients are. That's where the money is, and where the money is where people want to be. And unfortunately, that secondary goal of certificate of need never materialized. And so all that's left is this system that is intended to make, bigger hospitals bigger and make, other hospitals not be able to go into those systems. And I think that when you get rid of certificate of need, there's, I don't know if those rural areas are going to get those hospitals because there's still an issue there. And I think we need to figure out how to make sure that they get the care they need. But having certificate of need is not the solution. And so I think that that's what's important, and I think it's only causing harm, and it's not causing any benefit.
Let me ask a question. Raise your hand if your state does not have certificate of need laws. Raise your hand. Keep your hand up keep your hands up a second. Put your hand down if you have no hospitals in your state. Those states. The answer is that's the answer, is people behind you raise their hands, they have no certificate of need laws. We know that they also have hospitals in those states.
Yeah.
So the discussion is if you eliminated certificate of need, then the hospitals would collapse, and we know that that's not true.
That's definitely not true.
There's a new book coming out, I think it's probably this fall, by John Hyman, and essentially, why does healthcare cost so much? And his answer is because it's designed to. That the healthcare system in the United States is designed to do one thing: take a lot of money from consumers and patients and give it to special interests, the insurance companies, the hospitals, the doctors. And that is essentially the way we've designed the system, and that's the ACA fits in that, the previous regulatory regime fits into that. All the laws essentially fit into this idea that it's designed to take money from people who are sick and give it to people who treat them. And CON is essentially certificate of need is part of this process that is essentially set up to take money from people and give it to the interest that exists today, and that essentially run the system today.
And I had a conversation with Newt Gingrich. He was here, and he actually wrote an op-ed in support of our technology. And in the conversation, he made a great point. He basically said, when you take $100 billion out of healthcare, and it's $100 billion of savings in healthcare, you're taking $100 billion away from somebody else. And that's $100 billion of people who have lobbyists who don't want that $100 billion of income to go away. So that is the problem with saving money in healthcare. And I think that goes to the core issue of, if we want to bring healthcare down by $500 billion, that's $500 billion of income someone has.
I want to, we don't have that much time left, but I want to go to the audience for questions, healthcare policy issues that you're facing in your states. Any questions you have for our panelists?
Can we start over here?
Sure. Glenn, go ahead.
Thank you. Glenn Mulready from Oklahoma, and I actually have two questions, if that's okay. The first is on the marketplace discussion. Year one in Oklahoma, we had 6 insurance companies. Year 2, we had 4. Year 3, we had 2. It was looking like we were going to have 1, and then 2 months ago, Aetna announced they were going in, but last week they announced they weren't. The one carrier left is Blue Cross Blue Shield, who has a 70% rate increase filed. That I'm assuming if the feds deny that they will pull out as well. The only thing I can think of is the feds then contract with someone to have an option, a public option, or they go to some sort of federal employee benefit plan hybrid or something. But I'm wondering if we're facing that in other states, has that been discussed or what that looks like? And then if I can, the second question having to do with nurse practitioners, something I'm chewing on this summer. Has it ever been done or looked at to expand that scope of practice, but specific to primary care shortage areas within a state? In other words, it wouldn't be statewide. In our state, the 2 metropolitan areas wouldn't expand scope of practice, but maybe in the rural physician shortage areas they would. Okay, thank you.
I'll try to answer the second part. Our state, probably most states, maybe all states, do not allow you to target certain counties or whatever based on legislation. You can't go, you can be a nurse practitioner having this expanded scope of practice, but only in wherever. The best way to do it that I've seen of any for our state as well is we go to kind of this fictition of if your county is over 500,000 people or less than 10,000 people, then you can do A, B, and C. But you probably have the same thing in Oklahoma. Bottom line, you want to get those the expanded scope, I think, is an easier discussion for even those entities that are trying to protect those interests. It's an easier discussion if you could guarantee that the rural communities are going to get the health care that you're looking for. But to incentive, I guess the other is incentives, and that's a whole other finance tax policy, pros and cons. But incentivize individuals to go to those rural communities. We do that for physicians through forgiving loans, student loans, for example. But weaving through all that, you probably got to look at your own laws to see how you do it. But everybody, as he said, typically many people want to be in the metropolitan areas where the standard of living, the education opportunities, et cetera, are typically better.
Yeah, as far as the last, insurance company standing, it's almost always going to be the Blues, I think, and there's going to be a lot of pressure put on them to stay put, especially if your Blues are the insurer of last resort, essentially, in your state in exchange for the tax exemption. I think that's basically it's going to be made a criteria for the continued nonprofit status, the continued tax exemption that they get in terms of staying on the exchange. So I think that's what I'm hearing some whispers about.
Well, that all creates a whole lot of problems for the physicians and hospital systems. We've got United Healthcare right now is in a battle with one of the biggest hospital systems in metropolitan Atlanta. And the battle is simply this, is we're pulling out if you don't let us reduce our reimbursements to your physicians and your medical professionals. And we know your population of United patients in your hospital from year to year is X. You can't afford to lose that money. So
yeah.
To Michael's point, the outcomes are challenging at best for the patient, and that's a concern.
Next question.
Good morning. State Rep Hardaway out of Tennessee. First of all, thank you for that historical background on the Masons. That I had no idea. I'm going to do more research on it myself. But thank you for that. When we look at the institutions that train our doctors and dentists and other healthcare providers, are they developing curriculums for telemedicine? Are they tagging it on? Is this something that the professionals learn after they're already in practice? What's the role of the medical schools, the dental schools, et cetera?
That's a good question. Does anyone know?
That's a great. I don't know.
I honestly don't know.
That's something wise to look into. That's a great question. Thank you.
Around telemedicine.
Are they teaching it in the medical?
Are they stressing it in medical school?
Honestly, I haven't researched that.
Try and look into that. That's a good.
It's a good question. I would hope that they would be, with Watson, with all of the technology that's being advanced, you would think that they would be. I actually don't know.
I know states like our state in Georgia has a telemedicine initiative that's incentivized and encouraged by the state. But at the end of the day, if we're not training up those professionals to use it as fast as we should, we need to do better.
And there's a lot of variation in curriculum in medical schools, both in terms of the overall curriculum and then in terms of the way it's taught as well. There's long been a discussion between West Coast and East Coast medicine, for example. I guess sort of like West and East Coast rap or something, but essentially, for example, if you have back pain, you're much more likely to get surgery if you've doctor graduated from an East Coast medical school than from a West Coast medical school.
Wow.
It's simply in terms of the training and the emphasis and things like that, the way they treat things. So I'm not sure there's a uniform.
And one thing I would say is telehealth it's been around for, I would say 20, 30 years of telephone and all that stuff. And the last 15 is when you see Teladoc has been around, which is kind of the biggest player, most well-known player. But it's really the only last 5 years that you've really seen an emergence of it where people are starting to accept it. The regulation is starting to become, reasonable for companies like ours to practice. And so that's why you're seeing this emergence across the three biggest companies. Last year, I think they did 1.2 million visits Teledoc, Amwell, and Doctor on Demand. So you're starting to see this expansion of actual use, and that's just gonna. I mean, I think we're gonna see 5 million visits, 10 million visits in the future.
Hi, my name is Chris Hansen. I'm a state senator from Montana. I had a question to follow up with you on the direct primary care idea. I've just briefly heard of it, so I don't have a lot of background knowledge on it. But so it's kind of a couple little questions. The first part is, it's a contract, so why couldn't a doctor and a patient do this anyway? A contract is generally a free market idea. But is it Affordable Care Act hindrances that it isn't considered insurance, or what would prevent a doctor and a patient from doing that anyway? And then the second part of the question is then, if folks enter into that arrangement as a primary care service contract, what happens then for serious illnesses or disease or emergencies and things like that? So,
Great questions. The first answer is it's usually insurance laws that restrict it. Most states that all the states that I've looked into, you're changing the insurance code to allow it because it's considered, anytime you're paying on a regular basis, which is a little bit different than concierge sometimes, but you're paying on a contractual basis, that's often considered insurance. I wrote laws, actually it's a model bill for American Legislative Exchange Councils, for wellness incentives, which, interesting idea. If you're going to stay healthy, then you should be rewarded in your insurance rate. Just like if you're a better driver than I am, then your automobile insurance rate should be less. If you're a healthier individual than I am, based on body mass, nicotine use, etc., then you should have a lower rate. Most states, that was if you had a lower health insurance rate, that was considered a rebate to the patient, to the individual who on the insurance contract, and that was against the law. So the states had to change it and eliminate that law there. The same thing here with direct primary care is it's considered an insurance contract between you and your doctor, and that's against the law. So that's what you're really changing. The second question was what if it's other services? So let's say you're going to an internist and you get a regular physical or whatever. In my concept was actually allowing it for OBGYNs, et cetera, I just wasn't narrowing it to primary care specialist. But let's say you're going to an internist and they see something, then they're going to refer you out. Same thing happens on a direct primary care contract, the exact same thing. So they're not, Dr. Jones over here isn't required to now treat you for everything that you've ever going to come up with, including open heart surgery and diabetes and whatever, they're going to refer you out. So there's a scope of practice, there's a scope of services.
are you insured for that? Referrals out? Who pays then for that?
You don't use the word insured because this is an insurance contract, but who pays for it? The answer is then you flow in this contract doesn't pay for it. This contract doesn't extend the $150, $300 a month concept doesn't go to, you can go to, have a cancer treatment or whatever. You're on your own. But keep in mind these are people that don't have anything. So we're not trying to solve all the medical issues for that individual. We're trying to keep them healthy. And the healthier population we have, the fewer people will end up showing up typically in the emergency room, which is probably 4, 5, 6 times more expensive than in a doctor's office. So what I would suggest, and that just lastly, is get a direct primary care contract. We need to change some laws, as Mike will address here when I say this, but do a direct primary care contract and layer that with a health savings account, which, for the sake of time, I'll talk to you offline. But to do that and have a high deductible there and have that be what's addressed is you're going to the higher levels of care that are required, that are a lot more expensive. I'll be here. I'll talk offline if I can be helpful.
Couple more.
Yes, a question for Michael. I'm John McAllister from Nebraska, and just wondering if there is a free market solution for the uninsured.
Part of it is to recognize what is the purpose of insurance. And insurance is essentially designed to spread risk. It's designed to take something that has a very small likelihood of occurring, but a very big cost, and to spread that over a pool. And think about, your homeowner's insurance. The chances that your house is going to burn down is pretty small. But if it does burn down, most people don't have enough cash sitting around to rebuild. So they take that small risk, that big cost, and they spread it over the entire population. But they don't use insurance to mow their lawn, which is a small cost and a very high likelihood of occurrence. And too much of our insurance has basically gone in that direction. If you actually use insurance for the purpose it was intended to be, it's actually fairly inexpensive to do. That type of catastrophic risk spread over a large population is actually fairly inexpensive. And if you do that, I think then once you lower the cost, then you can talk about the fact that you essentially have a cash problem for some people. And then it's a matter of giving them cash so that they can afford insurance in whatever mechanism that is. But first you have to bring down that cost for what is actually insurance. If you're talking about simply prepaying health care, there is no free market mechanism for that because you're chasing your tail forever, essentially, on that. And that's too much of what insurance has become.
My answer is direct primary, to answer your question directly too, is a direct primary care is a solution for the uninsured, coupled with a catastrophic health insurance plan. For a healthy male, it's probably $40 a month, and supposed a couple years ago in Georgia is $30 a month. So basically $400 a year, you could get a catastrophic plan. You're going to have a high deductible, maybe $10,000. Right now your deductible's the sky's the limit because you have no insurance. So you get a catastrophic health insurance plan, $400, $500 a year, or you do a direct primary care plan with it, and I think that's moving in the right direction. You're going to have to pay something, but really, to Michael's point, is the catastrophic plan achieves the true insurance policy that we pay for with homeowners and automobile insurance.
We have time for one more question.
Hi, I'm from Alaska, so when we talk about rural, we really mean rural, like the bush. And so do you actually have services in Alaska? And if not, is there barriers to it? Because we really struggle with getting our bush people care. We've actually just finally passed a law saying the insurance company can't charge different prices for behavioral health and mental health services via telehealth. And so we're really trying to expand that because we literally have to fly them to Anchorage, fly them back, and then what ends up happening is they plan all of their other stuff around that. So the state is actually paying for them to fly to Anchorage, have a vacation, fill their cars, fill or whatever, and then fly back while they're also having health care, and it's becoming very costly.
Yeah, we actually just opened in Alaska, I believe, and so that's the perfect example. I mean, this is, I would imagine a good chunk of those people we surveyed that said they don't have access to a doctor, could have been this number of them could have been from Alaska, and it's just that's the perfect use of telehealth, and it's not to say that every patient in Alaska can use telehealth every time. Sometimes you do need to go see someone, but in those situations, that's the reason why banning technologies like ours or other telehealth companies, technologies is just, it's just not reasonable, and it's going to hurt. It's going to hurt real people, right? These are real people, and it's going to cost the state money. Your example is the perfect example of the issue that banning our technology in your state, but other states, is it's going to cost the state money and it's going to cost your constituents money. And we, that's what we're trying to avoid.
And I also think a state like yours is where we need to talk a lot about scope of practice. I mean, I do think that that's a big issue. And I recognize the problem. Everyone wants to practice in Anchorage. Nobody wants to practice out in the rural communities, but sometimes having a dental hygienist out there, even if you can't have a dentist, is all you got. So they should be able to do more, or the physician practitioner, or the nurse practitioner, or so on, and be able to do that in those communities. It's a huge issue.
I want to thank our panelists for their insight and knowledge. We're going to go directly into our education panel. So if you're on the education panel, if you'll come up here. But could you give our panelists a round of applause?